Thank you for the introduction. I'm going to talk about my favorite subject, migraines. And migraine description exists for as long as anything was recorded in human literature. Going to Greek mythology, Zeus was suffering from debilitating headaches and asked god of blacksmith Hephaestus to take his axe, strike his head, and end his misery. That's how Athena, the goddess of war, was born. Interesting story. Among those who suffered from debilitating migraines were many prominent, famous people: Queen Elizabeth I, Queen Elizabeth II, Virginia Woolf, Julius Caesar, Tchaikovsky, Chopin, Guy de Maupassant, and on and on and on. And the question is, can anyone experience migraine? In research, that answer was provided by triggering migraines with nitroglycerin and more recently CGRP inhibitors infused in intravenously. Migraine has been defined as a headache that is moderate to severe in intensity, throbbing, pounding, pulsating. It is caused by activation of nerve fibers within the wall of blood vessels traveling through meninges. And it is the sixth most disabling condition in the world. It's also has been estimated as prevalent condition in 2009, present in 1.1 billion of people. So very impressive. More common in women, as we know, and criteria for migraines that I personally do not always follow, if ever, is that migraine attacks that occur over your lifetime with typical migraine symptoms, no underlying cause, at least 5 times. And there is no biological marker or test for migraine, with an exception for hemiplegic migraines, where there is a genetic screening that can be performed quite successfully. Untreated attacks can last anywhere from 4 to 72 hours, but it's not always the case. It certainly can last longer. And common symptoms include sensitivity to light, smell, sound, heat, motion, and when they're particularly severe, nausea and vomiting. Any exertional activity, movement, coughing, Valsalva can exacerbate the symptoms, and frequently migraines occur in the morning. It's believed to be as our brain prepares for wakeful state and goes from rest to wakefulness, that becomes a trigger because a great deal of neurotransmitters are released, and oftentimes it pushes the brain towards migraine state. Some patients have predictable times of migraine recurrence. In women, they can recur perimenstrually. There are headaches termed letdown migraines, which tend to occur after a period of intense work, often on a weekend, and then obviously very frustratingly spoil your weekend. And letdown migraines are triggered by the fact that all of the stress-related activity at work suddenly is over, and brain perceives fairly profound shift in neurotransmitters and other very potent molecules, which becomes a trigger of a migraine. Migraine characteristically has 4 stages. Not every patient recognizes prodrome, and common symptom of prodrome is irritability or unsuppressible yawning. Some patients become acutely depressed. Some patients get a great deal of energy, and some patients have other symptoms like low energy and myalgia and so on. Prodrome can last for a few hours, but also can last for a few days. And sometimes you can teach the patient to recognize it, because treatment can be more effective if earlier stages of migraines are recognized. 20% of migraine sufferers have aura. Aura can precede migraine headache, but oftentimes actually can be associated with migraine headache and last anywhere from few minutes to 60 minutes, aura that lasts greater than 60 minutes is considered to be a typical aura. Headache does not do justice to description of migraine. We get description of migraine as a profoundly intense, debilitating pain, ice pick-like sensation, getting stabbed in your head, pounding, throbbing, and it commonly starts with one side, hence hemicrania, which means migraine is termed to be hemicrania, which means one side of the head, and evolves into another side. It's not always true for children. I find that most children tend to have bilateral headaches, and those headaches do not have prominent migraine features. Children are less likely to be very sensitive to light or sound, but more likely to have motion sickness. Prodrome, that patients called hangover, can last for several days or several hours. And hangover headache means the head pain is nearly gone, but patients often experience allodynia or unpleasant sensation in response to even gentle touch that involves their cranium, or brain fog, as well as other symptoms, low energy, somewhat cognitive sluggishness. So each stage certainly can present with disability. Migraines are common, and experts estimate that half of adult population experience headaches, and 12% of Americans get migraine headaches. Women are more commonly experience headaches. The ratio is 3-to-1. That ratio is 1-to-1 in teenage young girls to young boys. And at menarche, where typically migraines begin, that changes because of hormonal influences. And predicting who can get a migraine is very difficult, although typically migraine sufferers, most migraine sufferers, have first-degree relative. It's estimated that 80% of patients have first-degree relative, father or mother, with migraine disorder or disease. Most commonly, migraines occur between age 15 and 55, so in very productive patients in population. And functioning during full-blown migraine attack is impossible, or next to impossible. Stress level can contribute to migraines, and smoking can contribute to migraines. There are a number of new treatments. In the past, though, migraines have been treated with various concoctions. I was just describing to my colleague that I recently read early intervention, should we put it that way, where vinegar was mixed with laudanum, and laudanum was medieval preparation of opium. And compress was applied to the forehead of a patient so that vinegar would dilate superficial blood vessels and the opiate would be absorbed in patient's skin. Obviously, I don't see how well that could help, but perhaps it's better than nothing. The other really barbaric treatment that existed in medieval Europe was trepanation, or driven a hole in someone's cranium to release evil spirits. Luckily for us, we don't have to deal with any of that now. In 1926, first ergotamine treatment was released. And ergots existed for many, many, many years. Again, at medieval times, persons who suffered from migraines used to pick up spoiled wheat and eat it. And you could see even in some prominent paintings, these dark fingertips related to over vasoconstriction caused by ergot, because it helped the headache, but obviously wasn't a medicinal approach which would balance therapeutic benefit against drawback and side effects. In 1983, sumatriptan was released in June. It celebrated its 41st birthday, so to speak. And it's changed the world of migraine treatment a great deal. There are 7 triptans. They're all slightly different. They come in various formulations: sumatriptan, rizatriptan, zolmitriptan, elatriptan, elmatriptan, tromatriptan, and naratriptan. The least triptan, the triptan is at least prone to side effects, is actually elatriptan. And it's also prone to least side effect because it's less vasoconstricting. Triptans bind to 5-HT1B and 1D receptors, and 5-HT1B receptor binding is responsible for vasoconstriction and are responsible for a lot of side effects associated with triptans, which sometimes involve feeling that your throat gets tight and your jaw gets tight and painful. Other side effects include nausea and fatigue. The delivery method is very important. Obviously, if patients have nausea and vomiting, which commonly occur in association with migraines, the delivery method is important, and you change it to either intranasal or injectable form of medication. Sumatriptan and zolmitriptan all come in that formulation. Longest-acting triptans are frovatriptan and naratriptan, and because of their long half-life, they're often used for treatment of perimenstrual migraines. They can even be taken scheduled rather as needed. Ergotamine, so alpha-1 selective vasoconstriction medications, are migraine-only antidepressant. There are more than that, but these two are intranasal. The challenge with approving them is, I'm not sure whether you deal with the same thing, Dr. Wei, but I can't ever get an approval from insurance company. Not any longer, although medication usually is fairly well tolerated and has long half-life. So that's important. Long half-life means it would be less prone to rebound headaches. One of the most important things we try to convey to our colleagues that migraine sufferers are cursed with rebound headaches. If migraine sufferer uses any analgesics, particularly short-acting analgesics, over-the-counter or prescribed, more than 2 days in 1 week, it puts the patient at risk of rebound headaches. Rebound headaches become notoriously persistent and very challenging to treat. For one, you have to stop taking it and give it time, which is obviously already challenging for patients who need to take care of their family, go to work, and have a lot of responsibilities. Over 6 years ago, first calcitonin gene-related peptide inhibitor, Aimovig, was released. Aimovig is an injectable monoclonal antibody that binds to the CGRP receptor. And this category of medications changed my practice, and I assume other neurologists' practice. Medications are first preventative specific treatment for migraines. In the past, we had to literally borrow treatments from other fields, use something that was designed for different purpose, such as beta blockers, commonly represented by propranolol or metoprolol, or anti-seizure medications. Topiramate is very commonly used. Gabapentin is relatively commonly used. Depakote or verapamil are commonly used, although they have their limitations, especially in childbearing group of patients. We use antidepressant medications such as tricyclics, amitriptyline, nortriptyline, venlafaxine antidepressant, but none of those medications were designed with treatment of migraines in mind, whereas CGRP inhibitors were. There are several CGRP inhibitors that actually prevent migraines: Aimovig, Jovium, Galati, and infusion once every 3 months infusion VAPT. Injectable medications are typically self-administered once a month It's a very convenient treatment and give a lot of flexibility to patients as well as independence. It's not prone to side effects, although like with any medicine, side effects can occur. More commonly seen side effect is actually constipation with Aimovig. It can occur, although to a lesser degree, with Ajovy and Emgality. And the site of injection, induration or irritation, or even allergic reaction. And usually we find a way to deal with that. Rarely we have to switch treatment. There are preventative medications, Qulipta and Nurtec. Nurtec is by all means unique treatment because it can be used as abortive when taken as needed, or as preventative when it's scheduled every other day. Even when patients experience side effects with CGRP inhibitors or calcitonin gene-related peptide inhibitors, they tend to be milder than triptans. Some patients are very sensitive to triptan medications, and triptans have limitations in patients who have uncontrolled hypertension or high blood pressure, coronary artery disease, or stroke. They cannot be used in anyone who had TIA or stroke. It's contraindicated because they're vasoactive. There is another unique medication, dietane-lasmedian, that is not vasoactive. It binds to 5-HT1F receptor, so it's not a vasoconstricting medication. And its unique property characterizes it, since we can actually give it to patients with certain risk factors that would preclude triptans from being used. But lasmedian is a sedating medication and has contraindication for driving for 8 hours. So one can easily imagine using it, though, for nocturnal migraine. If a patient takes it during nighttime and doesn't have any early morning commitment, that could be a good treatment strategy. My favorite medication, Nurtec, or orally disintegrating treatment, typically very well tolerated, although dry mouth and queasiness with initial use certainly have been reported. It acts quickly, and close to 50% of patients can be symptoms-free by 2 hours after taking medication as abortive treatment. Most of the preventative treatments within CGRP inhibitors require anywhere from 4 to 6 weeks to even begin to work. Although for some patients, they can tell therapeutic effect sooner than that. For example, with Qulipta, I had several patients who after week 3 reported some benefit. Abortive treatments include Ubrelvy, Nurtec, and Zavspread. Ubrelvy is an oral medication. It takes a long time to begin to work, but it works really well in some patients. Zavspread is a nasal spray, and the drawback of nasal spray is that they can drip down the throat, and some patients mind it a lot because apparently it doesn't taste good. Some patients learn this trick of tilting their head for a few seconds and allowing medication to be absorbed, and then it's less likely to create that unpleasantness of dripping on the back of the throat. There are several migraine treatment devices, and while they're available, their drawback is expense. Cephali has been around for many years. It was released in 2008. These treatments have both preventative and abortive treatment modality. It's very easy to use Cephali, and when it's used preventatively, every day patients run a program for 20 minutes that prevents migraines, and as abortive treatment, there is a specific treatment for 60 minutes that can stop migraine. The cost, however, runs upwards of $400. And unfortunately, I have never succeeded to get it through anyone's insurance. Nerivia is a newer treatment, which is less expensive, more accessible to patients. They wear it over their forearm. Nerivia is approved for persons 12 and older, and very straightforward to use, and can be programmed for preventative therapy as well as abortive treatment. Single pulse transcranial magnetic stimulator is probably my favorite, and also is the most expensive. These treatments, specifically cephaly or Nerivia, because they're at least cost manageable, a very good choice in patients during pregnancy because of limitations of what can be used during pregnancy. At the present time, sumatriptan can be used as abortive therapy. Patients can drink a little bit of caffeine, encouraged to take naps, rest, stay hydrated. But in general, pregnancy means few treatment choices. And that's when cephaly becomes one of the better choices. I always tell my patients that they have 3 months to decide whether this investment is worth their while, because within 3 months they can return the device if it doesn't help. My subject of particular interest is migraine and PFO. I will show you what PFO looks like. There it is. PFO stands for patent foramen ovale. Patent is open, foramen is a hole, ovale, it's oval. Patent foramen ovale is not a pathological structure. It's a hole that exists in the heart of developing fetus that doesn't use lungs yet. And the blood circulation gets rerouted through the hole from developing fetus, from mother to unborn child. When a child is born and begins to use lungs, within the first year, patent foramen ovale closes. If it persists at 3 years old, it's never going to close, and patent foramen ovale is graded. 0, no hole, 5, very large hole, and you wouldn't be able to hear a murmur from patent foramen ovale, even with patients valsalving, because of the location of the actual hole. It doesn't cause murmur on clinical examination. Approximately 25% of general population have patent foramen ovale. It's usually small and inconsequential. And if found, it's an incidental finding. That changes in patients who have migraines with aura. Patients who have migraines with aura, with or without headaches, or patients who have chronic migraines, particularly intractable migraines. The role of PFO is not terribly well understood, but again and again, we find an association not only between migraine and patent foramen ovale, but migraine and patent foramen ovale and stroke, and I will talk about it a little bit more. Typical aura versus atypical aura. Aura is usually visual and believed to be caused by cortically spread event in the brain. Visual aura can take form of blind spot that getting bigger, 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 or crescent that shimmers initially in the center of visual fields and then travels peripherally until it dissipates. And most visual auras last for a few minutes, if not seconds, but certainly can persist. And any visual aura or sensory aura that lasts longer than 60 minutes is considered to be atypical aura. There are some neurological symptoms associated with migraines that can persist for several days. It's certainly more common in hemiplegic migraines, but some patients can experience numbness or heaviness on one side of their body for many hours, if not for many days, and then it's considered to be an atypical aura. Patients with atypical aura are much more commonly have patent foramen ovale. In the presence of PFO, according to several research studies and meta-analysis, is around 79.2% compared to 46.3% in those with typical aura. Another study found that 67% of migraine sufferers have PFO if they're chronic migraine sufferers, particularly migraine sufferers who have more challenging to control migraines, and I will allude to why that might be, or at least believed to be. Several studies indicated that in general population, aura can occur, as we already discussed, up to 25% and tends to be small, whereas in patients with prolonged aura, atypical aura, which is one and the same, any type of aura or intractable migraines, the likelihood of finding PFO is much greater. There is an association between migraines with aura and a stroke. And that association has to do with the fact that if the PFO is present, there is a potential communication between venous circulation and arterial circulation. And if there is a crossing of microemboli or emboli from right to left side of the heart, it's termed paradoxical embolism. We always include diagnostic workup of potential PFO in patients, particularly with cryptogenic or type of strokes that don't have any obvious risk factors. PFO is diagnosed by several potential modalities. One is a cardiac ultrasound or echo with bubbles, and what it means is that patients get the test and the IV is placed. The nurse uses agitated saline that gets injected into the vein. It's perfectly safe. And then the echo technologist begins to monitor for any crossing of bubbles from right side of the heart to left side of the heart. And the speed of crossing and number of bubbles characterizes the size of PFO. The usual report that one can get from this type of study is that there is a presence of shunt, right to left shunt, at rest and with Valsalva. Why is it important to perform Valsalva maneuver? Under normal circumstances, the pressures on the left side of the heart are greater than on the right side of the heart. But even normal daily activities, like bending, lifting, coughing, having bowel movement, can transiently equalize the pressures, and that would permit crossing of metabolic byproduct or microembolies from right to left into the brain. Usually, metabolic byproducts are cleared within lungs, and metabolic byproducts that are active in migraine sufferers would be something like serotonin and other neurotransmitters broken down, or hormones that brain typically does not perceive unless they cross from right to left to the brain. And one of the studies performed in UCLA reviewed 712 patients with a stroke. 127 of patients had cryptogenic stroke or had no obvious stroke risk factor, such as high blood pressure, high cholesterol, atrial fibrillation, atherosclerosis, And with those patients, cryptogenic stroke patients, they found higher prevalence of PFO, again, close to 80% or 79%. And patients who had cryptogenic strokes and migraines had PFO often as high as 93% of the time. A number of studies found that incidence of PFO in migraine sufferers, again, can be as high as 66%, whereas in general population, anywhere from 9 to 27%. Why is it important? In chronic intractable migraines, where doctors and patients try very hard to establish triggers and modify them, and there are modifiable migraine triggers and not modifiable migraine triggers. Modifiable migraine triggers certainly would involve food. If the patient can establish their food trigger, that would be helpful. Lack of sleep is a big problem for migraine sufferers, so patients are encouraged to go to sleep at the same time, and dehydration is a modifiable trigger. There are multiple triggers that are not modifiable. We live in the Northwest, so barometric pressure changes very frequently, and for a lot of migraine sufferers, it is a fairly significant contributing factor. Non-modifiable trigger is also menstrual cycle, although some patients, when they use hormonal birth control, can stabilize it to a certain extent. So we encourage our patients to find modifiable triggers and, as much as possible, modulate them and hopefully achieve less contribution. Nowadays, one of the big triggers for patients who work, well, everybody works with computer nowadays. We treat a lot of software engineers who stare at the computer or some kind of screen all day long. And that visual strain and overstimulation becomes a trigger as well. There are certain ways we can advise the patient to try to modify it, but it is quite challenging. With PFO, it can be potentially a significant trigger, because if intermittently metabolic byproduct that's supposed to go through the lungs, be cleared and be done with, actually crosses from right to left to the brain, from right to left to the brain, and that is a very potent trigger, and then it can contribute to migraine chronicity and challenges of controlling patient symptoms. It also obviously plays a significant role as a stroke risk factor, because if the tiny microemboli are frequently crossing, what happens is it triggers low perfusion in the brain where emboli settle, which is usually and tiny penetrating arteries, and trigger cortical spreading depression. And cortical spreading depression is involved in causing visual migraines or visual aura or other type of auras. The initial relation between PFO and migraine was actually anecdotally observed in divers. If divers ascend quickly, little bubbles within venous system can be formed, and if the bubbles bypass the lungs and the diver happened to have a patent foramina valley, it can cross directly to arterial circulation, travel to the brain, travel to other organs, and cause decompression sickness. We're all familiar with that. And also anecdotally, in divers who had their PFO closed, not only it actually had effect on decompression or risk of decompression sickness, it also lessened frequency of migraine attacks. Over the years, since I've graduated from medical school, multiple PFO trials were conducted. And none of them, and the trials were conducted with the purpose to determine, should there be a recommendation for migraine sufferers to have PFO closure if patients were found to have PFO? Unfortunately, none of the studies and their primary endpoint. And primary endpoint would lead to recommendations to migraine sufferers have PFO closure if they happen to have PFO. However, in sub-analysis, especially in the premium trial and in meta-analysis, it was found that patients who had aura or atypical aura, consistently migraine attacks, in fact, responded to PFO closure. And patients had fewer migraine attacks, and there fewer incidences of aura. The symptoms control was improved. I have several patients who underwent PFO closure because of concomitant stroke risk factors or even strokes. I certainly have treated patients who experience migraines with prolonged aura for many years and then unfortunately actually presented with symptoms very similar to what they commonly had for many years. And those symptoms worsened and resulted in a stroke. And my interest in PFO was actually dictated by one of my patients who almost always had aura preceding migraine attack, and on a day when I treated him for a stroke, presented to emergency room with visual cut that was more dense and wouldn't resolve within anticipated period of time when it's commonly began to improve for the patient. We immediately sent the patient for brain MRI imaging. It showed stroke and occipital distribution. He received TPA and did remarkably well. Later on, when I came to see the patients, he actually did ask me that, how is that? He was my patient for 10 years, and I have not managed him to be tested for patent foraminal, which happened to be the cause of his stroke. We've never found the where the thrombus came from, although not uncommonly patients can have deep venous thrombosis that subsequently travels up, crosses from right side to the left side of the heart to the brain, and causes the stroke. There is also no guideline in existence when a neurologist or any doctor should test their patients for patent foraminal valley. I do it routinely for patients who have prolonged aura, or aura that lasts for more than an hour, or very complicated symptoms associated with their migraines, as well as MRI findings that look like that. Interpretation provided typically by neuroradiologists for this brain imaging would be non-specific subcortical abnormalities. This non-specific subcortical abnormalities must have a cause. And I suspect that the cause could be related to microemboli crossing from right to left to the brain and causing areas of ischemia. Frustratingly enough, for some patients, and I have several patients with abnormal brain MRI, cause of which is not established nor understood, but continues to progress. And I've tested my patients for certainly hyperlipidemia, unusual lipids like lipoprotein A, etc., aprotein B, and they all routinely have PFO that tends to be greater than 2 in size, and 0 being no PFO, 5 being a very large PFO. They have no indication for PFO closure because none of them, thankfully, had a stroke. And yet, they certainly have compellingly, abnormally looking brain MRI. I tend to screen my patients for hypercoagulable disorder. And then for some patients, depending what does that screening show, whether there is any propensity towards hypercoagulable disorders such as factor V Leiden, which is most commonly found in women because it renders protection during childbirth, so it's passed along genetically because of the genetic advantage, and we find not uncommonly heterozygous abnormality of factor V Leiden in patients who I test. And then I converse with my patients about lack of any guidelines or standard recommendations, but my firm belief that they should take daily baby aspirin. One of these days, hopefully, one of the trials that would be more selective for patients with migraine symptoms will prove that certain subcategory of patients with migraines and aura or chronic migraines that are difficult to control would benefit from PFO closure, especially if they have concomitantly abnormal brain MRI imaging such as this. Well, thank you for your attention, and if you have any questions, I will try to answer them. All right. Any clarification one wants to discuss about medications or migraines or PFO?
I did have a question about when you were talking about that PFO closure helped improve the aura. Did it also help improve the migraine?
Yes. 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 I only have 4 patients who had PFO closure because they also happen to have strokes. One cerebellar small stroke, another slightly bigger occipital lobe stroke. And when the PFO closure was indicated because of stroke, we have seen improvement in migraine symptoms. Yes.
Can you explain again what exactly aura is?
Aura is a sensory experience that precedes migraines. Only about 20% of migraine sufferers have aura. Aura is usually sensory, which means often visual. And it's usually a visual obscuration. We have various terms for it. Scotoma, but what patients commonly described is scintillating scotoma, is like a crescent, and it's intensely bright. It starts in the middle of visual fields and shimmers and begins to travel to the periphery of the vision until it's gone. Some patients experience blind spot and become bigger and bigger and bigger. Some patients look at the paper and can't read as if somebody took a bite out of their vision. And there are other type of auras described as shimmer. Some patients describe it quite rarely, as if you're looking at the broken TV. And there is a description of associated symptom called visual snow. Most of the things that patients experience are visual. However, it also can be numbness, usually unilateral numbness, or tingling in paresthesias. That can be a form of aura. Patients can describe heaviness. Another rare form of aura would be difficulty to articulate. We call it aphasia. Certainly. Well, thank you for your attention.